of the dysplasia. So now we are going to see the Neoplasia 2, which will consist of molecular basis of cancer. And remember that a cancer is known as a malignant tumor. It's not a benign tumor. So the outlines is cancer epidemiology, molecular basis of cancer, clinical features of cancer, laboratory diagnosis of cancer, and tumor markers. Concerning the cancer epidemiology, most of the cancer, it occurs over 55 years, but there are some cancers found in children. For example, leukemia, central nervous neoplasma, and bone tumors like osteosarcoma. These are found in children. So cancer is not for older people, it is also found in young people. In children, it has a good prognosis compared to the old people. So about the cancer can be hereditary. If you have done genetics, you understand what is hereditary. So it can be autosomal dominant or autosomal recessive. For those autosomal dominant, you can see the retinoblastoma. This one is found in the tin. Familial adenomatous polyposis, hereditary disorders caused by mutation of adenomatous polyposis. It is in colon. Autosomal recessive syndrome. This one concerns about the DNA repair. The group found there is hereditary non-polyposis carcinoma, the most common. It is in a colon, intestine, endometrium, and the ovary. There are some familial cancer. Example, those colon, breast, ovary, and the brain, meaning that there are some families which are targeted or sharing those genes of cancer. Features that characterize the familial cancers include early age at onset, tumor arising in two or more close relatives of the index case, and sometimes or bilateral tumors. It has been estimated that 10% to 20% of patients with breast or ovarian cancer have a first or second degree relative with one of those tumors. But don't think every case of breast it is familial. For this one, to check if it is familial, there are some genes you have to check, like those black one and black one. So those mutation occurs no more than 3% of the breast. But when this gene is there, meaning that the patient has more, the relatives has more chance to develop a cancer. I don't know if it is a chance or my chance. There's some acquired paraneoplastic lesion. I've seen those squamous metaplasia and dysplasia. Once there is no proper treatment of those squamous and dysplasia, this one can develop to a cancer. Endometrial hyperplasia and dysplasia, also they are paraneoplastic lesion. For example, for a female over 55 years with vaginal bleeding, you can suspect endometrial carcinoma. And once you found endometrial hyperplasia, this one can lead to endometrial carcinoma. There is some leukoplakia of the oral cavity, fever, penis, which may progress to squamous cell carcinoma. Villus adenoma of the colon, even though adenoma is benign, but once there is no proper treatment, this one can develop to colorectal carcinoma. Here you say about the precancerous condition. They say certain non-neoplastic disorders can find some chronic atrophic gastritis, or pernicious anemia, solar keratosis of the skin, chronic ulcerative colitis, leukoplakia of the oral cavity. Those they can develop to cancer. This is why they are known as precancerous condition. But it doesn't mean every case of chronic gastritis will develop to a carcinoma. Here there is a long list of those pathologic conditions leading to a cancer. For example, asbestos, this one will lead to asbestos and silicosis. This one can lead to lung cancer. Cystitis, inflammation, bladder carcinoma, gingivitis can lead to the carcinoma, inflammatory bowel disease. Here there is a long list. You will have to read yourself. But there's some, for example, AIDS, HIV. This one can lead to, you are exposed to non-Hodgkin lymphoma, squamous cell carcinoma, or Kaposi sarcoma because of human immunodeficiency virus. And the Kaposi is linked to herpes type 8, if you have done your virology. Osteomyelitis can lead to carcinoma, carcinoma of the epithelial tissue due to those bacterial infection. Chronic cystitis can lead to rectal carcinoma. This one, it is, you must know, a schistosomiasis type of schistosomiasis, hematobium. This one can cause bladder cancer. If you have done your parasitology, you know what is schistosomiasis. Let us see what we call a carcinogenesis. Carcinogenesis is a multi-step process at both phenotypic and genetic level, resulting from accumulation of multiple mutations, meaning that when we diagnose the cancer, it is not enough to continue to check mutation, because once there is a mutation, there will be poor prognosis. So in cancer, there is environmental inherited factors, environmental, chemical, radiation, viral, bacterial, and the others, as we have seen. So this one is known as carcinogenesis. Genetic damage due to mutation. They say a single cell which has genetic damage undergoes meiotic proliferation. So they form a tumor mass. So they say, where are the target of genetic damage? They say in molecular basis of cancer, there are 4 regulatory genes. Here we see the growth promoting Proto-Oncogenes, growth inhibiting, what we call suppressor genes, gene regulating apoptosis, and the DNA repair genes. These are 4 regulatory genes which are involved in carcinogenesis: promoting, inhibiting, regulating apoptosis, and DNA repair. What do you mean by proto-oncogene? Proto-oncogenes, it is a normal gene that can become an oncogene due to mutation or increased expression. Proto-oncogenes code for protein that help to regulate the cell growth and differentiation. Proto-oncogenes have multiple roles participating in cellular function related to growth and proliferation. There are some proteins encoded by proto-oncogenes. which may function as growth factors, or they are receptors, signal transducers, transcription, or they're involved in the cell cycle component. Oncoproteins are encoded by oncogene generally sub-function to their normal counterpart. However, mutation convert proto-oncogenes into constitutive active oncogenes that are involved in the tumor because the oncoproteins, they encode the cells with cell sufficiency in the growth. They say oncogenes are genes that induce transformation phenotype when expressed in the cell. A discovery in cancer was the realization that most of oncogenes are mutated or overexpressed version of normal cellular genes, which are called proto-oncogenes. Let us see those proto-oncogenes. There are some growth factors, receptors, signal transduction proteins known as RAS, nuclear regular proteins, and cell cycle regulators. Oncogenes code for oncoproteins. Maybe this one you have seen it in your molecular biology. A signal transduction is a generic term which refers to any process by which a cell converts one kind of signal or stimulus into another. To convert one kind of signal or stimulus into another. Here there is a long list of those proto-oncogenes. Here we see those growth factors, platelet growth factors, fibroblast growth factors, and along we see the proto-oncogenes. We see mode of activation. It can be overexpression or amplification. Example, there is overexpression of those platelet growth factors in astrocytoma and osteosarcoma. In case of stomach, there is overexpression of the growth factors with the proto-oncogenes is HST1. You see some TGF factors, they are overexpressed in astrocytoma. And this one, HGF expressed in thyroid cancer. Growth factors receptors. EGF receptors, these are overexpressed in squamous cell carcinoma of the lung and some gliomas. So you see here there is a long list of those proto-oncogenes. I don't ask you to memorize all those growth factors. What you must know is that some growth factors through the proto-oncogenes, they can have point of mutation, amplification, and this one will lead to a malignant tumor. You see signal transduction proteins, those killers. Mode of action is point of mutation found in the colon, lung, pancreatic, renal bladder. BRAF, you see a BRAF in melanoma, beta-catenin, point of mutation in hepatoblastoma, hepatocellular carcinoma. Nuclear regulatory proteins, CMYC, this one is found in Burkitt lymphoma. NMYC is found in neuroblastoma. And this one, MYC, found in small cell carcinoma of the lung. So you see there is a long list of proto-oncogenes which are involved in the carcinogenesis. Here they say acquired environmental DNA damaging. This one like chemicals, radiation, virus, this one will go to the normal cell. Then the normal cell will have a DNA damage. And then after that, there will be DNA repair. There's some genes involved in the DNA repair, like those P53. Then there will be mutation in genome of the somatic cells. In this condition, there can be activation of growth-promoting oncogene, alteration of genes that regulate apoptosis, and some gene suppressor, this one for inactivation of the cancer. And this one will lead to expression of altered gene products and there's loss of regulatory products. So this one will lead to coronal expansion, additional mutation, heterogeneity, and by at the end, they will have a malignant neoplasm. So here there are some steps involved in carcinogenesis. They say main change in cell physiology that lead to formation of the malignant phenotype. I think you know the difference between genotype and the phenotype. So there is self-sufficiency in growth signals, sensitivity to growth inhibited signals, a version of apoptosis, limitless explicative potential, certain angiogenesis, ability to invade and metastase. So now let us see one by one. Self-sufficient in growth signals. They say under physiological condition, cell can be resolved into following steps. This one it is in cell biology. The binding of growth factors to a specific receptor on the cell membrane. Transient limit activation of the growth factors, which turns activated several signal transducing protein on the inner reflect of the plasma membrane. This transmission of the transducing signals are across the cytosol to the nucleus by second messenger or cascade of signals transduction molecules. There is induction and activation of nuclear regulatory factors that regulate DNA transcription. Entry and progression of the cell into cell cycle, resulting ultimately cell division. You see here it concerns about the cell division and how the cell protects itself. In this case of self-sufficiency, there's some oncogenes, the gene that promote autonomous cell growth in cancer cells. They are delivered by mutation in Proto-Oncogenes. They are characterized by ability to promote cell growth in the absence of normal growth promoting signals. For this one, they say you have to remember the cell cycle because all those changes pass through the cell division. They say there is a binding of a growth factor to its receptor on the cell membrane. Then there will be activation of the growth factors receptors leading to activation of signal transducing proteins. And then there will be transmission of those signals to the nucleus. And then there will be induction of DNA transcription. So in that case, there is an entry in the cell cycle and cell division. They ask how cancer cells acquire self-sufficient in growth signals. We have seen the involvement of growth factors. Cancer cells are capable to synthesize the same growth factors to which they are responsive. For example, in the case of sarcoma and glioblastoma, those are factors TGF alpha, the PDGF. Growth factors receptors, they are also involved where there is overexpression. expression, the cell becomes sensitive and there is hyperresponsive to normal cells of growth factors. Example, this one, EGFR, like HER2. This one is amplified in breast cancer. This one will get the treatment of the breast cancer and will predict the prognosis. Even though there is HER2 is expressed, there is a treatment, Herceptin, called Herceptin or trastuzumab, but this one will have a poor prognosis. Even though there's a treatment, when you found there is the expression of HER2, but the prognosis will be poor. Signal transducing proteins, they receive signals from activated growth factors, transmit them to the nucleus, where we see some LAS and ABA. LAS, they are found in the colon and the pancreas. ABA is found in the chronic myeloid leukemia, it is a blood cancer, where there is translocation of 9 to 20. And this one also will predict the prognosis of the treatment of the chronic myeloid leukemia. They say chronic myeloid leukemia patients are treated with Gleevec, you will see it in your code, which is inhibitor of ABA kinase, meaning that once you are diagnosed chronic myeloid leukemia, we have to check for this gene, ABA, to predict the treatment and the prognosis. There's some nuclear transcription factors. Those mutations affect that genes that regulate transcription of DNA. For example, that MYC is the Proto-Oncogene, which bind to DNA, leading to the activation of the growth-related genes. MYC is found in Burkitt lymphoma, we see in systemic pathology, where there is translocation of 80 to 14 in the case of Burkitt lymphoma. I communicated that modern medicine narratives on about gene therapy. Here in our settings, do a diagnosis, but we don't have enough molecular equipment, reagent, and consumables to characterize those gene mutations. And what I can say, it is also expensive. Those molecular tests, they are very, very expensive. This is why most of them, they are used in research other than diagnosis. But with the progress in development of the country, we are hoping very soon to have those molecular unity of cancer. There are some screen and screen-dependent kinase. Those that are found in breast, esophagus, and liver cancer. And also melanoma and some sarcomas. So let us but with abnormalities. Here it is, they show an image of that growth factors, those suppressors in the cell cycle. I hope you still remember the cell cycle in cell biology. Retinoblastoma is an common childhood tumor. Retinoblastoma is either sporadic or familial. Familial in 40%. C2 mutation required to produce retinoblastoma. Both normal copies of the genes should be lost to produce retinoblastoma. Transforming growth factors, those on the make an activation of TGF beta, lead to cell proliferation, and then there will be mutation, and there will be cancer in 100% and 83, and colon cancer in 83%. Adenomatous polyposis coli, those they have a beta pathway. APC is a tumor suppressor genes. APC gene loss is very common in colon cancer. It has antiproliferative action through the inhibitor of beta-catenin, which activates cell proliferation. Individuals with mutant APC develop thousands of chronic polyps. And one or more of the polyp will progress to chronic carcinoma, meaning that once you found a colon polyp and you analyze, you have to check if there is no APC mutation. APC mutation, gene mutation, is found in 78% of the sporadic colon cancer. P53, this one it has function, mainly the tumor suppressor genes, antiproliferative, and regulate apoptosis. This one is involved in DNA repair. It induces DNA repair genes. If a cell damaged DNA cannot be repaired, it will be directed by P53 to undergo apoptosis. If loss of P53, DNA damage goes unrepaired. Mutation will be fixed in the dividing cells, leading to malignant transformation. This is an image showing that process. Example here, there's ionizing radiation, oncogene, gene. Here is DNA repair. There will be hypoxia. There will be transcription of the upregulation of target genes like a cyclin. And here there is successful repair. This one will go to the normal cells. For this one, because of the apoptosis, you see some apoptotic bodies. Here there is a cell death. In this one, on DNA damage, P53-dependent genes not activated. If not activated, there will be no DNA repair, and there will be expansion and additional mutation. This one will lead to malignant tumor. P53 is called guardian of the genome. 70% of human cancers have a defect in P53. It has been reported with almost all types of the cancer. Example, lung, colon, and breast. In most cases, mutations are required and can be injected, like in a Leaf-Fromen syndrome. Number C is inversion of apoptosis. Mutation in the gene regulating apoptosis are factors in malignant transformation. Cell survival is controlled by genes that promote and inhibit apoptosis, and that cell survival is controlled by the genes that promote and inhibit apoptosis. Reduced CD95 level inactivate death. DNA damage-induced apoptosis with the 53 can be blocked in tumors, meaning that loss of p53 and the upregulation of BCL2 they prevent apoptosis. Number 4 is limitless replicative potential. Normally, there is a progressive shortening of telomeres at the end of the chromosomes. Still remember the telomeres in your biochemistry. Telomeres is active in normal stem cells, but absent in somatic cells. So in tumor cells, activation of the enzyme telomerase, which can maintain, meaning that in tumor cells, there is activation of enzyme telomerase, which can maintain normal telomere length. There is also angiogenesis. Neovascularization have two main effects. Perfusion supplies oxygen and nutrient. Newly formed endothelial cells stimulate the growth of adjacent tumor by secreting growth factors, interleukin and platelet growth factors. Angiogenesis is required for metastasis. He asked, how do tumors develop a blood supply? The tumor-associated angiogenetic factors are involved. These factors may be produced by tumor cells or by inflammatory cells infiltrating the tumor. For example, macrophage. For this one, the important factor in angiogenesis, there is vascular endothelial growth factors, the fibroblast growth factors. These are involved in angiogenesis, formation of the new blood vessels. At the end, there will be ability to invade the metastasis after the angiogenesis. Here we see in the blood vessels, see the tumor cells. Here we see the metastatic subclones, adhesion of the basement membrane, passage through extracellular matrix here, intravasation, interaction with the host lymphocyte. Then here in the blood, there will be tumor cell embolus from the extracellular. And then there will be adhesion of those embolus. And there will be sorry. There will be adhesion to the basement membrane. And then there will be extravasation before there is intravasation. Then extravasation, and there will be metastatic deposits, and there will be angiogenesis and growth. So this is the metastasis pathway. So there is ability to invade in the metastasis. There are two phases: invasion of extracellular matrix, vascular dissemination, and homing of tumors, those embolus tumor. Then there will be what you have seen, invasion of extracellular matrix. Malignant cells first breach the underlying basement membrane, traverse the interstitial tissue, penetrate the vascular basement membrane, and gain access to the blood filtration. Invasion of the extracellular matrix has 4 steps: detachment of the tumor from each other, attachment of the cell matrix component, degradation of extracellular matrix, and then migration of tumors. Here there is loosening of transcellular junction. Here we see those cadherin, they are collagen. Attachment to the basement membrane. Degradation. Then migration to the blood circulation or to other site. In carcinogenesis, there is also what they call vascular dissemination and homing of tumor cells may form emboli. Most travel as a single cell, adhesion to the vascular endothelium, and then extravasation. So these are the main changes found in carcinogenesis. As a summary, self-sufficient in growth signals, insensitivity, evasion of the apoptosis, limitless replicative potential of the telomeres, formation of the new blood vessels, and ability to invade and metastasis. Here there is what we call genomic instability. It is an enabler of malignance due to a DNA repair genes. For example, Italian purposes, carcinoma, scleroderma pigmentosum, and familial breast cancer. Those they have a genomic instability. For example, here in familial breast cancer, it is due to the mutation of BRCA1 and BRCA2. Those genes regulate DNA repair. Cancer results from accumulation of multiple mutations, or they say all cancer have multiple gene alterations involving activation of several oncogenes and loss of 2 or more tumor suppressor genes. So there is what we call molecular basis of metastatic carcinogenesis. Here we see the morphologic appearance, and here there is the molecular change. In normal epithelium, there will be loss of mutation of the APC, focus on chromosome 5. In the case of hyperproliferative endothelium in the early adenoma, there is also loss of DNA mutation. Then there will be from the adenoma to carcinoma, there is mutation of RAS genes on chromosome 12, loss of suppressor genes on chromosome 18, and then loss of p53 genes on chromosome 17. So you see now, once there is loss of those p53 LAS, the cells are becoming malignant. Tumor progression. Many tumors become more aggressive and acquire general malignant potential. This is what they call tumor progression. It becomes by the transformation, progression, tumor cell variant heterogeneity. These are tumor cells, tumor variant. Karyotyping change in tumor genetics. We have seen the chronic myeloid leukemia, Burkitt lymphoma, follicular lymphoma. Those they have some translocation of the genes. There's some gene deletion, gene amplification, like those HER2. I've seen ABL oncogene this found in leukemia. Carcinogenic agent There are three categories, sorry. Can be chemical, radiation, or microbial agent. Let us see the chemical agent. They can be natural or synthetic. Some are direct, others are indirect chemicals. Indirect chemicals need metabolic conversion to be active and carcinogenic. Indirect chemicals are called pro-carcinogens, and the active end products are called ultimate carcinogens. All directly acting and ultimate chemical carcinogens are highly active and they have electron deficiency atoms. They act with the electron-rich atoms in RNA and DNA and the other cellular proteins. Example of those direct agents, like those alkylating agent used in chemotherapy. In treating cancer, you can also cause another cancer because of those chemotherapy and radiation. Polycystic hydrocarbons, these are found in cigarette smoking. What you must know, nicotine is not the one to cause a cancer. Nicotine will cause addiction, cause will attack on the ganglion cells. The one involved in cancer, cigarette smoking, they are those polycyclic hydrocarbons. Animal fat during the broiling meats, smoked meats and fish. That doesn't mean if you go in the bar, in the restaurant, you take one brochette, smoked meat and fish, doesn't mean that you have a cancer. But with routine of consuming excessive consumption of those smoked meat and fish, this one can cause a cancer. Example of indirect chemicals, aromatic amine and azides. This for example, naphthylamine cause blood cancer in the rubber industries and the aniline dye. Some other dyes are used to color some foods. Triazamine are used as preservative. Those they can cause gastric cancer. Aflatoxin B, produced by Aspergillus, growing proper stored grain. This one can cause hepatocellular carcinoma. For example, those who have the habit to eat nuts, like in Senegal, there are more cases of hepatocellular carcinoma. Here we see the mechanism of action of the chemical carcinogens. Most of them, they are mutagenic, EDS cause mutation. Last and p53, they are common target of those chemicals. Radiation, like ultraviolet, X-rays, nuclear radiation, therapeutic irradiation, these also can cause a cancer. UV rays of sunlight can cause also a cancer like melanoma, squamous cell carcinoma, and basal cell carcinoma in the case of those albinos. Albinos, they're exposed to basal cell carcinoma because this one, they can damage DNA. With extensive exposure to sunlight, the repair system is overwhelmed, and then there will be skin cancer. In that case, they cause mutation in p53. This one is involved in the suppressor, is also involved in apoptosis. Some microbial agents like DNA virus, RNA virus, and other organisms. Viral oncogenes, those card genes that induce cell replication as part of viral life cycle. The host cell has endogenous genes that maintain the normal cell cycle. And the viral infection mimic or blocks those normal cellular signals necessary for growth regulation. There's some RNA Oncogenic Virus, like a human T-cell leukemia, caused by RNA retrovirus target. This one is endemic in Japan and Caribbean. Transmitted like HIV, but only % of infected T-cell, they can develop a T-cell leukemia or T-cell lymphoma. In case of HIV immunodepression. They say for cancer there is no cure or vaccine. Treatment with the chemotherapy with common relapse can treat cancer also with irradiation. We receive those irradiation in your clinical practice at the Rwanda Military Hospital. A DNA virus, like those papilloma, human papilloma virus, Epstein-Barr, hepatitis B, Kaposi sarcoma, which type of herpes 8. This transcripted viral DNA transform blocks the host. Example, those human papilloma, they say there are about 7 types of human papilloma, but currently it is even over 100. This human papilloma can cause dysplasia of the cervix, anogenital region, mouth, and the larynx. And you must know that human papilloma now is in the group of sexual transmitted disease. And the HPV, it is not only for female, even for man. Can be found in some in the genital region, for the cervix, and some on the penis, and the anogenital region, mouth, and the larynx. I have said the papilloma is a sexually transmitted disease, which causes 85% of cervical cancer, which type 16 and 18. Type 6 and 11, they are benign. (16, 18, 31) type of HPV, these are carcinogenic. Overexpression of exon 6 and 7. This one can be found in retinoblastoma. E7 protein, which one bound to p53, facilitate degradation of the p53. E6 and E7, the proteins found in human papillomavirus. HPV infection alone is not sufficient. There are some other risks like cigarette smoking, coexistence of infection, and hormonal changes. Epstein-Barr virus, this one can cause bacterial cells of oropharynx. It is also found in the case of infectious mononucleosis. EBV may cause some malignant like Burkitt lymphoma, G-cell lymphoma immunosuppressive, the nasopharyngeal carcinoma. Cancer of nasopharyngeal epithelium, it is endemic in South China, part of Africa. 100% of tumors contain a given genome in an endemic areas. This is an image of a patient suffering from bucket lymphoma. This one is high malignant B-cell tumor. It is sporadic with flare occurrence. Worldwide, most affected are childhood. It is most found in Africa. In all cases, has translocation 8-14. They cause some B-cell lymphocyte proliferation, loss of growth regulation, and predispose to mutation. Hepatitis B will cause hepatocellular carcinoma. Helicobacter pylori, this one can cause a gastric carcinoma and gastric lymphoma. So a gastric carcinoma. What we call MART is mucosal associated lymphoid tumor. I've seen it in histology. Most of the time are those who are targeted in case of gastric lymphoma. Here they say the mechanism induced by Helicobacter pylori HP to cause the cancer. HP pathogenesis genes such as CAG-A and also may contribute to stimulating growth factors. Before we go to another chapter of clinical features of cancer, I would like to know if there are some questions about molecular basis of cancer. Question about molecular basis of cancer before we go to another chapter. Any question? Any question?
There is no question.
No question. If there is no question, we can go to the clinical features of cancer. They say tumor causes problem because of the location and effect on adjacent tissue. For example, 1 centimeter of pituitary adenoma can compress and destroy the surrounding tissue and cause hypopituitarism. 0.5 centimeter of leioma in the wall of renal artery may lead to renal ischemia and serious hypertension. Tumors may cause bleeding and secondary infection. Lesion ulcerate adjacent tissue and structures. Effect on functional activity. Hormone synthesis occurs in neoplasm arising in the endocrine gland. Adenoma and carcinoma of beta cells of islet pancreas produce hyperinsulinism. Some adenoma and carcinoma of adenocortex elaborate corticosteroid. So aldosterone induce sodium retention, hypertension, and hyperkalemia. Usual research activity is associated with well-differentiated brain tumor more than carcinomas. Is the cancer cachexia, weight loss, usually accompanied by weakness, anorexia, and anemia. Severity of cachexia generally is correlated with the size and extent of the spread of the tumor. Origin of cancer cachexia are multifunctional: anorexia, reduced calorie intake, increase the basal metabolism rate and calorie expenditure, remain high, and general metabolic disturbance. There is what we call Paraneoplastic Syndrome. These are symptoms that occur in cancer patients and cannot be explained. They are diverse and associated with many different tumors. They appear in 10 or 15% of the patient. They may represent the earlier manifestation of an occult neoplasm. They may present a significant clinical problem and be lethal. They can mimic metastatic disease. And the most common paraneoplastic syndromes are hypercalcemia, Cushing's syndrome, non-bacterial thrombotic leukocytitis. You will read in Robbins, there is a long list of those paraneoplastic syndromes. The most often neoplasm associated with these syndromes is lung and breast and hematologic cancer. Laboratory diagnosis. Laboratory diagnosis we have seen. First of all, there's microscopic tissue diagnosis using H&E. This is the gold standard, and it is the routine by excision or biopsy, which can be on frozen section, fine needle aspiration, cytologic smear, histochemistry, where there is antigen and antibody in the tissue. A flow cytometry is used routinely in the classification of the leukemia and lymphoma. This method, fluorescent antibodies against the cell surface molecule and differentiation antigen are used to obtain the phenotype of malignant cells. So there are some markers. These are used for measuring the level of the tumor-associated enzymes, hormone, tumor markers, and serum. They are used for determining the effectiveness of the therapy in detection of the recurrence after excision. For example, elevated level may not be diagnosed of cancer. PSA. Only few tumor markers are provided to be clinically useful. For example, CA and alpha fetoproteins. For PSA, even though it is elevated, doesn't mean always elevation of PSA meaning that there is a prostate cancer. So there's some molecular diagnosis, like a PCR, polymerase chain reaction. Detection of BCL, IBL, transcription in chronic myeloid leukemia. Example, we have seen this one, it is in molecular, we do a PCR, and then you see these genes for predicting the treatment. There is what we call fluorescence in situ hybridization. It is useful for detecting chromosome translocation characteristic of many tumors. So both PCR and FISH can show amplification of the oncogenes FAR2 and NMYC. So those is what we call molecular profiling of tumors, can be done both at the level of messenger RNA and by nucleotide sequencing. So you can do genotyping and sequencing. Expression profiling DNA microRNA. This technique allows simultaneous measurement of expression levels of several thousand genes. The principle of this is so-called gene chip. There is also what we call whole genome sequencing. We do sequencing for finding the mutation cancer. So for this one, molecular techniques, most of the time they are in the advanced lab developed the country. But also here in Rwanda, government is trying its best to have those genome sequencing for those tumors. It is a long journey, but we have to. Tumor markers. Tumor markers is produced directly by a tumor or as an effect of the tumor on the health tissue. Concentration increase with tumor progression. Highest level in tumor metastasis include diverse molecules such as serum proteins, oncofetal hormones, metabolic receptors, and enzymes. Ideally, a tumor marker would be a substance that is released directly into the bloodstream, detectable at a small concentration. Tumor specific, absent in individuals, readily detectable in body fluid. Unfortunately, all of the presently available tumor markers do not fit with the ideal model. So in the summer, there is no ideal tumor marker. Application of the tumor markers, screening population at high risk. For example, those alpha-fetoprotein in PSA. Not all tumor markers are good screening tools. No. For the diagnosis, use results from markers, imaging, risk factors to predict the prognosis. Tumor markers can indicate a growth. Monitoring response to the treatment. For example, in the case of data for more, we measure beta HCG. Decrease the level of tumor markers indicate the therapy is working. Increase the level of tumor marker may indicate need for a change to therapy. So here there is a long list of tumor markers. For example, for the hormone, human chorionic gonadotropin, trophoblastic tumors, seminoma and testicular tumors, calcitonin in medullary thyroid carcinoma, catecholamines in the metabolics, those of chromosoma, ectopic question. You are welcome. Yes. You are welcome. Please ask your question. Yes.
We know there is a slide which has said that there is no cure, there is no treatment, or there is no vaccine.
Sorry?
I wonder, there are some cancers which they can. There is a slide which has said that there is no cure or treatment, or there is no treatment or vaccine. So I wonder, there are some cancers which can be bajyana muri shiririze, I don't know. Barazishiririza zigakira rero. So I have a question about that slide. You can give me more explanation about that.
Maybe what you have seen, it was about the it was here about the this side.
Yes, this slide.
On this one, we're talking about the virus and cancer. Most of the time, we say that there is no treatment of cancer, but there's some, depending on the stage and the type of cancer, the cancer can be curable. And this one, it was combined by the virus. For the virus, until now, there is no treatment for the virus. But there are some cancer which are curable at early stage, and depending on the type. For example, those non-Hodgkin lymphoma, they are curable in children. Those seminoma, they are curable. But in general, we use chemotherapy and radiotherapy and the surgical treatment. Because the it was combined by the virus, you know, there is no cure for the virus. What we have is the vaccine, but we do not vaccine, or there is no vaccine for all virus. For example, this one, human T-cell leukemia virus type 1, lymphotrophic virus. This one, it has no cure or vaccine. Maybe it was a confusion. Okay?
Yes.
But the cancer are curable at early stage. Some type like those lymphoma in children, seminoma, these are curable. So here there is a long list of those tumor markers with them. For example, if we say tumor alpha fetoprotein, this one is for hepatocyte, seminoma, and some germ cell tumors. PSA in prostate cancer, CA125 in ovarian cancer, CA19 colon cancer and pancreatic cancer, CA15 in breast cancer. So as you have seen, there is no ideal tumor marker. They are not specific, but they can orient to the treatment. For example, this one, beta human colonic atrophy. This one, it is monitored in the case of those choriocarcinoma. If there is still an increase of HCG, it means that the tumor is progressing. When there is a reduction of this HCG, it means that the tumor is decreasing. This is what I have prepared today for about the molecular basis of cancer. What you must know of today is that after diagnosis of a cancer, you have to check the mutation to get the treatment and predict the prognosis. Any question? Yes? Hmm? Sorry? Don't understand. Don't. Here they ask, can tumor embolism cause the cardiovascular disorders such as blocking blood circulation, which may consequently lead to ischemia or hypoxia? So it is not like those blood clot. It may happen, but what this one will cause metastasis. For example, it was a breast tumor. Then there will be tumor cells which make embolism, then they go to the lung. In that case, there will be metastasis of that tumor from the breast to the lung. If they go to the lymph node, in that case, there will be metastasis. In that case, it will not cause the cardiovascular disorders first. First, it will cause metastasis, meaning that there will be cancer in the breast and then cancer in the lung. You will see those breast cancer cells in the lung or in the lymph node. This is what we call metastasis. Okay? Is it clear? Is it clear? Elvin Mujisha, are you satisfied? Elvin Mujisha, are you satisfied? Eh? Okay. So those tumor embolism will cause metastasis. This one, it will be a poor prognosis. Other question? Other question? Another question?
None.
No question?
Yes.
No question? And as we have said before in the presentation, after this presentation of Neoplasia 1 and Neoplasia 2, we have to do a cut number 2. Okay? Are you ready on the next first day we do cut on the neoplasia?
No, we are not ready, lecturer.
It is planned. In the presentation, there was that after neoplasia 1 and neoplasia 2, there will be a cut. Okay? It's okay. We can do a cut on Thursday. Okay. Sawa sawa. Okay. And the cut will be also online. And before you perform the cut number 2, I will have to give you the marks of cut 1.
Yes.
But I have seen some people with 100%. I'm not sure if they don't know. There is what we call technique. Maybe there's some technique there in the exam. I have seen some people with 100%. I'm not sure. Maybe there is a strategy.
No strategy.
Okay, continue reading using the logins and do some exercise. Okay? Those of Fugaku, are we together? Gaku campus, are we together? Gaku campus, are we together?
Yes, we are together.
Okay. So be informed that on Thursday there will be a cut on Neoplasia 1 and 2. Okay. If there is no question, you can stop here, then we continue next week. Someone is asking practicals. Practicals, it will be after that cut. There will be 1 week for practicals. Okay? Okay. Thank you. See you on Thursday.